Hello everyone and welcome to our cardiovascular imaging conferences. Usually they're on Tuesday, but certainly they're available for you whenever you are interested in reviewing them offline and throughout the world. And I'm Dr. William Zoghbi. I'm the chair of cardiology here at Houston Methodist. And it is customary for us to start the academic year to talk about basics of cardiovascular imaging. And it is our tradition here to start with echocardiography. So we'll go through some of the basics, its physics, etc. Try to not to make it too complicated for you, but at the same time give you enough information so that if you're in the echocardiography laboratory, you understand what's behind the images that you're seeing. Now, for those of us who've been in the field for some time, we've seen it evolve, but many of you who are maybe just starting, it's really nice to start where echocardiography has many applications. It is indeed a family of techniques that are available for you nowadays, for you to be able to image the heart or any other structure, because it's certainly not for the heart only, and understand not only structure, measure function of the various chambers of the heart, and also understand flow dynamics, quantitate flow, look at valvular heart disease, regurgitation. So if you take a look at this picture, it's really emblematic of what these echocardiographic techniques have evolved into. Remember that this is also in real time, which is really amazing for us to be able to see the structures, otherwise we don't feel. First one is an M mode, then a 2D with color, looking at aortic regurgitation, continuous wave Doppler, looking at an aortic stenosis, jet, contrast echocardiography, where you can see the heart better, particularly in difficult situations, automated strain imaging, another measure of cardiac function, 3D echocardiography, and a prosthetic valve seen in 3D through transesophageal techniques. So this is what we're going to go through, and I will start with some of the very basics of ultrasound so you understand what are we talking about. So when you talk about ultrasound, it is in the ultra audio range. Certainly your audio range is about 30K, right? So beyond that, and most of these crystals that are emitting, we're talking about in megahertz, so in millions of hertz. A wavelength that you could see here on the left. The frequency is how many cycles of this wavelength occur per second, right? So if you're talking about 3 megahertz, so these are 3 mega of these waves over seconds. If you have a shorter wavelength, you'll have a longer wavelength, obviously a lower frequency. And if you have a shorter wavelength, just like this one here, you have a much higher frequency. And it has implications from not from an audio range, because none of them you'll be able to hear, but it has implications as to what the resolution of what you're seeing. Okay? Remember that the speed of ultrasound in biological tissue is about 1,500 meters per second. So that's quite fast, actually. And if you think about it, whatever you measure, distance-wise, everything-wise, is basically solving that equation. You know what the speed is, and you know how long it takes for that image to come back to you. It's reflected because it has the same reflection of light, and basically you're solving for that time distance. So if we take a transducer, and on the tip of the transducer are some piezoelectric crystals, and these crystals are very responsive to 2 things, but nowadays we use one thing. It used to be responsive to a mechanical stimulation. So if you stimulate a crystal, it will emit a certain wave, but nowadays we could excite it with electricity. So it's a electrical excitation. When you excite this crystal, it will emit a certain frequency. Now, we usually emit them in bursts like this, because if you emit them continuously all the time, you're not going to be able to take the advantage of the properties of finding how far a certain image is. For those of us who grew up in mountains and you can hear your echo after a while, just imagine you send a sound and you wait for it to come back, so it bounces against the mountain, comes back to you. But if you keep screaming all the time, you'll have no idea, right, that you're merging your own voice with the reflected wave. Okay, that's why we send bursts. Now, once you send a burst against a certain surface, what happens to it? Just like light, at a certain angulation, some of it is refracted, so it goes further down, and some of it is reflected, and usually at a symmetrical angle. So just imagine if this is the same transducer that you are waiting for these reflected ultrasound to come back to it, and this very fine red light that you see, this is the only energy that comes back to you for you to be able to reflect and understand how intense it is and how far it is. Okay? So most of actually what you send is not reflected back. Okay? And also one principle which is very important for you here is that the best visualization is perpendicular to the structure. And why? Just imagine this transducer that we've taken and is now perpendicular to the surface structure. This little thing here is now going back into the ultrasound. So the red and the white dashed will be going back into the ultrasound, and it will be the maximal reflected sound from that structure. An example, clinical example. If this is an interatrial septum, your best visualization is in a perpendicular situation to it, which is the best is a subcostal view. The worst situation, and that's what you see at times, is in the far field, further away from you, and parallel to it, which will be the apical fourth chamber. So it's in a way, it's in a miracle that we're seeing so much of that interatrial septum, and most of the time you may see a dropout, you're not going to see it. Doesn't mean it doesn't exist. It's further out after the interventricular septum and in a parallel kind of situation. And remember, for those of you who know, it's opposite to Doppler. Doppler, the best signal is you're parallel to it. For imaging, the best signal is perpendicular to the structure. Okay? Okay, now, so we send this burst or packet of ultrasound, okay, usually 3 or 4 of these wavelets. And if we have one more reflectant than the other, and the A mode, which you don't see nowadays and you don't even hear about it, it's an amplitude mode. It's basically how much of that is sent, reflected back to me. It's from the same transducer that is listening now and said how much of this frequency I'm getting back. And if it is more intense, I'm going to see it as a bigger amplitude compared to the first one. A B mode, and that's what you see nowadays, particularly on 2D, etc. All the other imaging is basically B mode, which is brightness. So a certain structure is reflected back, and the vector is flipped towards you, 90 degrees, so that the image is much more intense for a more reflectant structure. So take 2 things. 1, a myocardium, 2, another piece of calcium, just like mitral annular calcifications. All right? So you know where the depth is, which is the time that it took to be reflected back. And the intensity of it is, the calcium is much more reflectant, so the refraction portion that keeps going back is much less, and the reflectant portion is much more. So I see it much more bright. Okay? So another principle for you to remember, if I go back to this, if my reflection of this surface is very, very strong, it doesn't allow me to refract behind it. you're going to have shadowing. You're not going to be able to penetrate with ultrasound and see structures behind it. Your best example, a mechanical valve in the mitral position that's reflecting most everything back, and I won't be able to see anything in the atrium as well as you'd like to see. Okay? So the more reflection you have, the less refraction and the less penetration you're going to have after, this particular structure. Okay? So that's B mode. What's an M mode? An M mode is for motion. So if I take this dot, this bright mode, and I give it, I spread it over time, what is happening to this dot over time? Okay? So if I have a piece of calcium that's not moving anywhere and I give it a time, it will be a straight line. If it's moving up and down during the cardiac cycle, that's what you're going to see down below, right? So the mitral valve, you're going to see it up and down. The aortic valve, you're going to see it. So that's what you see on an M mode, right? This is a scan of an M mode through various cardiac structures. This is level 1 at the aortic valve. And what happens to the aortic valve here is during systole, it opens up. This is not the actual structure of the valve, but it's telling me what's happening during the cardiac cycle. It opens like a box because this cusp and this cusp is opening and staying open for some time, and then they close. And once they close, there you go. I have one line that's moving a little up and down because the cardiac base moves a little bit. If I'm at level 2, close to the mitral valve, what do I see? I see the RV free wall, I see the right ventricle, and it's obviously through this ice-pick view of the heart. I see the septum. That is ideally for this should be thickening a little more. Whoever renders it, it's not pure and good. The mitral valve, if you see the anterior and the posterior leaflet, it has almost like an M and a reverse M because that's what's happening to the mitral valve. Diastasis, during diastasis, then with an atrial kick, it opens up again, and then it closes, okay? And in the ventricle itself, if I'm at level 3, I'm going to see thickening of the septum. This is the RV, and this is the posterior wall, all right? What's the beauty of an M mode is its time resolution. It's beautiful for time, and you can take a look at the motion of a particular structure. Most of the time, we rely less on it than in the past. In the early days, you had to be, as a sonographer and experts in doing your sweep of an M mode, et cetera, much more reliance on it. And nowadays, we have 2D and 3D. It's much less important for us to be able to do that. How do we construct a 2D image? Well, remember, 2D is a B mode, is a brightness, right? So and this brightness is rather artifactual right here. It's not, you have a pericardium there. You have a little tiny area space between, and you have the muscle, and you have the right ventricle, and left ventricle, and the aortic valve, and all that is nice and dandy here. And how do we do it? Interesting enough, for the heart, as opposed to other structures using ultrasound, we have a small window for us to be able to image from between the ribs. So we have a sector now that moves these scan lines from one place to another, as opposed to if you want to take a look at the carotids, you don't have such an issue. So you could have linear probes as opposed to a sector probe, just like this one. Linear probe, the lines will come up and down along parallel to each other. Here, you're going to have to spread them apart over time. So you can think of what's called line density. How many lines do you have? And you sweep through them, initially mechanically, but nowadays electronically. You sweep them from 1 all the way to almost 100 or so, 120 of these scan lines that you have. And it's done fast enough for you to see almost in real time. The frame rates are updated minimum 60, 70, and usually more than 100 per second, which is amazing, really. So it's really close to very real-time imaging of the structures. Notice one thing is that since they're emanating from this here, from the transducer where the transducer is, as you go further and further out, there is more spread of the actual scan lines. And therefore, some of your resolution will be less the further out you're in the field, right? Your best resolution, as we talked about, is something perpendicular to it. It's along the axial resolution. And we'll talk about axial and other resolution. So axial resolution is along the scan line, okay? Along this scan line, how can you differentiate, a dot from here to a dot here, okay? If you cannot differentiate them, they're gonna look at a one phase, right? And you could tell already from what we talked about is that if you have a transducer that's emitting a higher frequency, let's say a 5 megahertz as opposed to a 2.5 megahertz transducer, the wavelength is smaller. And if the wavelength is smaller, I'm going to be able to differentiate two dots that may be closer together, as opposed to if I have a much longer wavelength, that I'm not going to be able to tell that these two are actually separate. They're independently separate. So that's why at times the image may look more blobby, because if you use a lower frequency transducer, your resolution is not as good. Now, the other one is lateral resolution. So it's the ability to differentiate two dots in the lateral portion as opposed to the axial portion of your emanating beam. Thing that you can do nowadays is, you saw these beams here, is you could focus them. You could electronically focus them, that you can have the narrowest portion is closer maybe to whatever you desire. And if they're close enough, you're going to be able to differentiate these two from each other. But the further out you're in the far field is going to be very hard. The resolution is going to be, much harder for you to be able to differentiate. You can still play around with it, but it will be. So in general, axial resolution is the best. Lateral resolution is not as good, okay? And the higher the frequency, the better your resolution. But also there is a trade-off. If you have a high frequency, you may not be able to penetrate as much. So a lower frequency transducer and somebody who's difficult to image may have a better penetration. Nowadays on the machines, you see high penetration, high resolution. That's in the behind of what you're thinking. Basically, they're changing what frequency you're sending. There are a lot of controls, so we're not going to go through each one of them, but there's an overall gain, time gain compensation. Remember, anything that you do is time related, okay? So the depth that you're talking about is time gain compensation, basically depth, lateral gain compensation, reject, the lower frequencies are taken out, compression, and there is a mechanical index. In the past, we didn't pay as much attention. The regulatory people, you obviously take always a look at how much energy you're sending out to the body, right? Remember, with ultrasound, you can have lithotripsy. You can be very strong, so it depends on the energy. And here, the mechanical index is the energy that is framed within physiologic ranges that doesn't hurt the body nor the structures that you're talking about. Interestingly enough, all the others that you see, 1, 2, 3, 4, as opposed to the mechanical index, are post-processing, meaning the ultrasound wavelets came back, and I'm processing them in a different way. The mechanical index or output power is the one that you're sending towards the patient, and then you also can manipulate that. Now, this came to more importance, if you will, from a clinical point of view, to adjust your mechanical index setting because of contrast imaging. And early on, we found out that if you send a lot of energy, the output is very high to these very fragile bubbles, and the bubbles could be filled with air or inert gas. They could have a different shell, etc. We'll have another talk about contrast. But you could destroy them depending on their energy, right? And the destruction, remember, we're talking about microseconds here, but the destruction is in the negative portion of the curve, of the phase or pressure curve, right? Because then you expand it so much that the shell bursts basically, etc. Which means that depending how much you want to see and how much contrast you want to see and what applications you have, most often you're going to aim for a lower mechanical index so you don't destroy as much microbubbles for you to be able to see it. And what is high and what's low? High is like a 1.5 or so, and low is like 0.1, 0.2. Okay? So these are the numbers that we're talking about. Another thing that you could see, and I already alluded to, is reverberations and attenuation, shadowing in a way. So if you have a very high, this is a transesophageal approach, you have a mechanical valve here, you can see these reverberations, interesting enough, that occur because of the properties of this mechanical prosthesis, but also in addition to the reverberations that you see, you have shadowing. You're not going to be able to interrogate what's going on here. And that's why, with ultrasound, a transthoracic approach and a transesophageal approach complement each other. Take an example. I have a prosthetic valve in the aortic position or in the mitral position. In the mitral position, I can see flow coming through the ventricle. I can't see much going on in the atrium itself. I do a transesophageal. I emphasize the reverse of such. Okay? So it depends of where's the reflectant structure and what's happening behind the reflectant structure. You can have artifacts, no question about it. And the artifacts could occur from multiple things, but one thing is particularly close to the transducer. I have the transducer here. I have these tiny crystals, many of them crystals. I'm bursting some wavelets that go out to them. But besides the crystals, there is casing, and on top of casing, if you've ever seen an inside of a transducer, it may go back and forth, reflects these ultrasound, and you may have what looks like a clouding area, and you don't know whether this is a thrombus, yes or no. What you would try from a sonographer point of view, and that's why for all of you, you have to train in addition to interpret. You know, fellows usually gravitate towards the interpretation station, gravitate first towards the actual machine station before you start interpreting the studies, because you need to understand what you're looking at, right? So yes, you could change position of the transducer, you could change the frequency of the transducer, all right? Or you could use contrast if you want to, and this is, you know, such an example. You couldn't see whether there was a thrombus, yes or no. There are some shadows, you can tell. Here you certainly have a thrombus formation. So if I want to reflect on what has happened over time, and it's amazing that at least the new trainees, the one who have lesser white hair than Mike Quinones and I have, because we leave it natural. I mean, it's amazing, and I'm so glad that you're at this stage of the game, so you could take the technology and run with it, and maybe develop it further, and at least use it for better diagnosis and management of your patients. We started with video and printout. We're fully digital. Very high frame rates. The frame rates were much lower, so better real-time imaging. Improve image quality because of better transducer, better penetration. Multi-frequency transducer. Some of you sonographers have been in the field in the past. We had to change one transducer to another. Oh, give me the 5 megahertz transducer, give me the 3.5, give me the 2. No more. You change what the transducer is emphasizing, which frequency. It's a multi-frequency. Harmonic imaging we'll talk about. Contrast echo, tissue Doppler, an innovation of the same principle. Speckle tracking and strain imaging as part of your daily routine nowadays. Digital imaging storage, used to be videotapes, real-time 3D echo. You can have portable ultrasound, you can have so many things. Really amazing. So let's go through some of them that are important for you. Harmonic imaging, okay? What's harmonic? If you remember your physics, I'm not going to make it complicated for you, is F is the fundamental frequency that you're emitting at. And if you emit it against a certain structure, that structure may resonate and give multiple or even a sub, but usually a multiple of that frequency. 2 times F, 3 times F, they're usually lower intensity. And maybe your best depiction of such, if what is it? If you're a string player, if you're a piano player or guitar player, if you hit that chord hard enough, you will hear more than the fundamental frequency that that string will send. Okay? If you want to imitate it, bang, versus bang, okay? They're lower, different sounds. Okay? So what does this have to do with ultrasound? Part of this actually depiction and discovery is playing around with contrast. Actually, this was developed for contrast. And why? Because these tiny micro bubbles are very sensitive to being hit by a certain frequency, by a wavelet. So they resonate. And when they resonate, they emit a second frequency, third frequency. So the thought is, if I emit at a certain fundamental frequency, but I listen at double the frequency, I will emphasize contrast as opposed to the other structures, thinking that the native myocardium doesn't resonate. Interestingly enough, the native myocardium resonates. Not as much as microbubbles, but it does resonate. And that's why on most of these machines that you use, most often it is on a harmonic imaging as opposed to pure fundamental imaging. And why? Because it takes away some of the clutter that I showed you. It takes away some of the clutter that I showed you. So let's go through some examples here. So basically, so what is it that when you say I'm imaging at harmonic imaging, if my transducer is at 2.5 megahertz, I'm listening at 5. Okay? So you could see them there, 2.5. It doesn't mean, interestingly enough, it doesn't mean my resolution is higher. My image is clearer. And if you remember the first two slides, my resolution may not be higher because I'm sending the fundamental frequency at a lower frequency, as opposed to a 5. If I'm sending a 5 and listening 5, okay, I have a high frequency and I have a better resolution. But I'm sending at 2.5 and listening at 5. It's not going to improve my resolution. It will improve, take away some of the clutter, and certainly improve contrast imaging. That's an example. That's an old example. Probably should get a new one. Somebody in apical hypertrophic cardiomyopathy, on a fundamental imaging, I really cannot tell you what it looks like. It looks more like clutter. On the right one, I could see that there is some apical hypertrophy. I could see where the cavity is. This one, I can't tell where the cavity is. Okay? It's clearer, not necessarily higher resolution. The resolution is not that bad, even at 2.5. Okay? Now, this is a bad image, no question about it. And if you use contrast, it can improve the image significantly, right? But we're going to talk about contrast per se down the line. But, to illustrate the issue, this is fundamental imaging of a contrast echo. Not the most pleasing, right? You could see contrast maybe in there in the middle. I could see the heart a little bit. That's about it. Okay? So this is fundamental imaging. Just with split of a second, by you turning on harmonic imaging, that's what you're going to see. This is the same heart, same contrast, same everything. Again, telling you that contrast is much more sensitive to harmonic. It emits much more harmonic than the myocardium per se. Now, to make it easier for you, nowadays there are presets on these machines, so you don't have to. In the past, we had to kind of bring down the mechanical index and also make sure that you're on harmonic. But if you push contrast, basically nowadays, it will do two things. Go to harmonic if you're not already on one, And two, adjust the mechanical index to be down so you don't destroy as much. Okay? All right, so that's imaging. We're going to talk about Doppler. Okay, what do we have in Doppler? Well, we have different nomenclature. Pulse, usual things that you hear about is pulsed wave Doppler versus continuous wave Doppler. I mean, you don't have to be a scientist or a PhD to figure out that there is a difference between pulsing, right, and continuous. I mean, my goodness, right? Not that hard. Now, under pulse Doppler, color Doppler is actually under pulse Doppler. You don't think about that, but it is a modification of the pulse Doppler technology. And a spectral where you see, you usually put your sample volume and trying to do, and you see an aortic flow and a mitral inflow, et cetera, et cetera. So let's go through them. Doppler is the name of a physicist, Christian Doppler, right? Born in Salzburg, and I think if you go there, that's what you're going to see. You're going to see a plaque, and interestingly enough, where he was born is very close to who's the other person who's big famous in Salzburg, born there? Mozart, you got it. And believe it or not, they're less than a block apart. Less than a block apart. It's all music, you got it. All right. Just imagine, born in 1803, fortunately died at 50, all right? And this physicist, through looking at, what did he look at? How did he discover the Doppler equation? Stars, the motion of stars, which tells you that they were living at a time where they could see the stars as opposed to not seeing the stars at night, right? So, but it's amazing actually, that equation is still unmodified, and it really is amazing. So what's this principle? Okay, before going through the equation, what's this principle? The principle is, if I have an object that is emitting a certain frequency, and it's either I am moving in relation to something else, or something else is moving in relation, that frequency changes. If that object is coming towards me, it compresses those wavelengths, so it will be higher. And if it's going away from me, it will be less compressed, and the frequency will be lower. An example is not too far from you here, right? Is you could stand on Main Street or Fannin, whichever way, and listen to either the ambulance or the train coming. Close your eyes, and you should be able to tell that this train is coming towards you. You should be able to tell when it crosses you, and you should be able to tell when it goes away from you, right? Because the sound goes up, amplified, higher frequency, then lower frequency. So it also tells you that if you're almost perpendicular to this thing, you're not going to be able to hear a difference. Take an example. It's either you are, that comes very close to you, and you'll be able to tell. But if you go further away, much further away, that you're almost perpendicular to its trajectory, you're not going to be able to discern as much of a change in that frequency, although the emitting sound is exactly the same. All right? So that's the principle, okay? Positive shift if the target is coming towards you, and a negative shift if it is going away from you. Which means if you're perpendicular to it, you're not going to have any shift. It will be exactly the same frequency. This is an illustration that's special from Miguel Quinones, because that's his handwriting, and I kept it because
40 years ago.
In the past, Dr. Q, when I was sitting in your chairs, used to give this lecture, okay? And amazing. Like maybe we should do a role reversal, Miguel. So, and you'll see many of his handwriting things, and this is 40 plus years ago. So this is an example of the arch. The arch is a beautiful example in the cardiovascular system where the flow is coming towards the transducer, then being perpendicular to it, then you won't have much of frequency shift, and then it goes down, and you should be able to see it by pulse Doppler or even by color Doppler. You'll be able to see the same. And this is the Doppler equation. Doppler equation is a frequency shift, positive or negative, depending on the velocity of that thing, which is blood. F0 is the fundamental transducer frequency that you have. Cosine theta, okay? Cosine theta, if it is 0 or 180, right? Perfecto. If it is 90 degree, 0, okay? And then in between, you're going to have lessening of that frequency shift. In the old days, early days of Doppler, the y-axis of what you see nowadays as velocity used to be frequency shift. It used to be in kilohertz. And then you had to do mathematical things, but computers were invented for such. So it was, the velocity is there, which means that the implication solving this equation is that theta is either 0 or 180. No adjustment for angulation. And we usually, most of the time, don't adjust for angulation because flow is a 3D vector. You see the 2D portion, unless you're really very comfortable with where the flow is going, you probably should not. And we adjust our transducer position till we get aligned inherently that the velocity is highest. Take an example, aortic stenosis, right? You use the apical, you use subcostal, suprasternal, right parasternal, all of these, and you pick the highest one, which tells you I'm the least angulated, because there is no way for you to be able to see the direction of the jet. Got it? All right. So we solved, the machines solve for the equation, and usually we say 20 degrees or more, you're going to have significant decrease in the velocity that you're seeing, significant decrease. So you'll underestimate what the actual velocity is. Got it? So remember, imaging perpendicular to the structure, axial resolution. Doppler, parallel, right? Remember that. Okay, pulse Doppler. Pulse Doppler. What do we do in pulse Doppler? Pulse Doppler is interesting because in that field, I want to understand what the velocity is, which is frequency shift. So if I put this pulse Doppler, let's say in the LV outflow tract here, I send this burst of a packet of frequency, of wavelets, okay? Now, if I want to know at that level what the frequency, what happened to this frequency? Did it get compressed? Or did it get, decompressed, if you will? What happened to it? I have to wait for the time that it takes for the distance to go back and forth, okay? So the time for me to listen to that frequency shift is the time that it takes from apex of the heart to go, let's say, about 8 centimeters and come back, so 16 centimeters. Then I'll open my gate and said, what happened to the frequency? Is it exactly the same as the fundamental? Is it higher or is it lower? And we use for this a fast Fourier transform analysis, which is a complicated way to solve what really happened to this. Just imagine mumbo jumbo of what happened to these frequencies. And that's where you come up with your spectral display of what the velocities are over time. It's really very accurate. That's number one. Number two, it has a good time resolution to it, right? So, but this is the pulse wave Doppler technology for you to be able to tell at the tip of the mitral valve, in the LV outflow tract, whatever that you want, what is the actual velocity is. So this is an example in the LV outflow tract. So I have in early systole, all the red cells, basically this is a reflection of the red cells, what they do, all the red cells are going at the same speed. When they start slowing down a bit, You may have spectral dispersion, okay? And then lessening of the velocity till aortic valve closure, okay? Now, the modal velocity is the one that has the majority of these red cells, so usually it's not the maximal. But we found out that actually you're closer to the maximal velocity as opposed to the vast majority of red cells because there is some underestimation, et cetera. So we use most of the time. And it's more reliable, more reproducible among people because I know where the edge is as opposed to figuring out where the modal velocity is. Okay? And then you have a mitral inflow. You could see it there. And I'm assessing where that velocity is. There's a phenomenon of aliasing since I use a pulse, then I have to wait. Just imagine if the structure is further and further and further away, I have to wait longer. So if the velocity is much higher, the frequency is much higher, I may not be able to solve it. Similar to a strobe, if you still go to a dancing place or whatever it is, right, and you have a stroboscopic light, you may not be able to tell the actual motion of a person if your frequency of emission is rather low compared to what the person is doing. Same thing here. Okay? So it has to, the pulse repetition frequency has to be 2 times, at least 2 times higher than the actual, frequency of that individual. Now you could do some baseline shifting, right, to try to increase that, but that's about it. And that's why in mitral regurgitation, for example, as opposed to the mitral inflow, you have this what's called aliased because I cannot tell which direction. So I have all this around me. Why? Because mitral regurgitation jet is much faster. I have to have an incredibly high pulse repetition frequency for me to be able to solve it. Yes, you can with high PRF, but usually you use continuous wave Doppler for you to be able to solve it, right? So how about color Doppler? What's color Doppler? Well, color Doppler is a modification of pulse technology. It's multi-gating. These are multiple sample volumes, but you can't use, because of complexity, you can't use the fast Fourier transform analysis. You use an autocorrelation or just an approximation of what the mean velocity is, right? And it's in a way multi-gate, and that's why you detect, basically regurgitation direction and everything else. Can't quantitate as well because you have easily wrapping around higher aliasing possibilities. Remember, we talked about also that in the arch, if you're perpendicular, you're going to have a black thing in between, the reddish versus the bluish colors. Now, a lot of factors can influence such, right? Gain, color maps, frame rate, Nyquist limit, and here, this is the same mild aortic regurgitation. I increase the gain, it increases significantly. So you got to be very careful about that. The Nyquist limit, which is the bar that you see here, if this is the Nyquist limit, meaning if the velocity exceeds, let's say 21, is going to wrap around and you're going to have multiple of those. If you decrease for whatever reason the Nyquist limit, you will overemphasize the smaller velocities. So this is a mitral regurgitation at Nyquist limit of 21. Very low Nyquist limit. Nyquist limit should be closer to 50, 60, or 70. Same patient with a Nyquist limit of 57. Mitral regurg looks much less impressive than the first one. Because, again, you're emphasizing the lower velocity, any little extra, and to the eye, the mitral regurgitation will look much more impressive. How do you optimize color Doppler? Problem with color Doppler is the frame rate is much slower than your 2D imaging. So it's influenced by the frequency of the transducer, scan depth. Why? Because if I have a depth of the scan all the way down, if I need it, that's fine. But if I have it all the way down, I have to wait for ultrasound to come back all the way. Depth, the width of the sector is going to take much more time to analyze it. So be mindful of that. Line density, how many times across each scan lines do you move to the second one to get an estimation of what the velocities are? So usually for us is optimize the depth and the width of the sector to try to optimize it. Hopefully you'll get the frequency, and always take a look at that. The frequency or the frame rate should be above 15 for you to be able to see something closer to real time. I'm not going to go through high PRF. I think, tissue Doppler. Most of the Doppler that you've seen ignores tissue. And it's interesting. We grew up without looking at tissue Doppler, color Doppler at all. It's very interesting because blood and tissue have different characteristics for the Doppler effect. In the tissue, the signal intensity is much higher and the velocities are much lower than in the blood, where the velocities are much higher and the signal that you reflect because of the red cells is much lower. So you could put a filter and say, I don't want that versus I want this. You could separate them very nicely. So take a look here. Now I have color Doppler of tissue, okay? Color Doppler of tissue. And because it's very different than the blood, you can isolate it differently. You don't have intermingling of these two structures together. Then came pulse Doppler, pulse tissue Doppler, that you could take a look at it. You use it for diastology and ventricular function. Then speckle tracking came, right? It's almost 20 plus years ago now. It's amazing. I was at the first presentation. I was blown away that actually you could track, these speckles of ultrasound, which is the nice thing about it is angle independent. And that's where you come to measuring strain, etc. What is strain? Is deformation. So if I have start at an L0 of 10, I shrink. Remember, if the structure shrinks, or it's a 3D, but most of the time we're not looking at the 3D portion, we analyze it into different planes. So if it shrinks down by 20% or it elongates by 20%, what is it? It's the difference in length, whatever that length is, divided by what you started with, right? L1 by L0 divided L0. And if it doesn't move, then you have a strain of 0. And nowadays we use the angle independent speckle tracking to do that. Strain rate we don't use as much, but ultimately we could, because it really depends, for ventricular function, it really depends on how fast the strain is occurring. So I have a low strain rate. It's the same strain on the left and on the right, and this is much faster. So it may tell you something about heart function as opposed to just how much deformation there was, in the cardiac cycle. So the three types of strain is circumferential, radial, and longitudinal strain. Most of the time that what you use is longitudinal strain. Remember that longitudinal strain may not necessarily mean just pure ejection fraction. They are not equal. They have a relation, but they're not equal. The best example for you is a hypertrophied heart who has a hyperdynamic function with an EF of 70%, yet where the strain is most is radial as opposed to the longitudinal. There's less descent of the base, right? So, but it has also significance, meaning hypertrophy alters longitudinal strain, alters prognosis at the same time. So it has different implications. So, but remember, it's a 3D rendering of what happened to deformation, relaxation, as well as contraction of the heart. And nowadays, all that is automated, which is really nice. It has its issues. At times, if the signal is good, imaging is good, you can't rely on it. So in addition to artificial intelligence, you need your own human intelligence. Remember that, okay? Up till now, you always need human intelligence to take a look at artificial intelligence. Okay? So numbers, what are the numbers? Usually above 17, they're negative because in longitudinal strain, the heart is shrinking, right? So to my purposes, we've written an editorial to take away the negative portion, but irrespective, whichever way you want to use it, as long as you use it intelligently. Above 18 or so is nice. The highest I've seen was about 34. It doesn't have a bell curve distribution. It is The highest is no more than 30 something. The lowest could be close to 0. Okay, and the vast majority of normals are between 18 and 20s, mid-20s. And this is a bad heart down below. You could see here, longitudinal strain is 6. Digital storage, why do I mention it? Because it's part of your routine. I like a 9-frame display. I can go through a heart first, get a feel of what this heart is about before you start quantitating and doing things. You could go through the whole heart within just few clips. The other thing is, this is where it helps you know where to measure and not to measure. Remember, this is tomographic imaging in the vast majority of the time, so you need to know which hearts are foreshortened, which ones are better, so you can help you choose by comparing, the various views. And it's an amazing technology that growing up we didn't have. So you realize and you appreciate it certainly much more, as you know. And last is 3D. Well, this is when we acquired 3D. This is April 2003, so 21 years ago. And the volunteer here was one of our fellows who was attending somewhere. I'm not going to tell you where. Not too far from here. All right? So, and that's the beauty. And even then, 20 some years ago, you could see that you could actually image the heart. At that time, we didn't have the capabilities to be able to see the whole heart in one beat as opposed to stitching, right? So at that time, and we still do that if the heart rate is fast or you need a better resolution, right? So you get this blob of 3D and then ask it to cut it in the midst of it, right? And then you could go from one section to another and quantitate various things. Certainly, we have improved significantly. We have high frame 3D resolution for you to be able to see that. You could quantitate EF with 3D. For the sonographers, please, because most of the errors are where the endocardium is, okay, and adjust where the endocardium is, because the tendencies for echocardiography is to be much more inner than a little bit outer. 1 millimeter or 2 millimeter difference can be 20, 30, 40, 50 cc depending on the size of the heart. So EF may be okay, but the stroke volumes and the quantitation may not be as good. You could do also regional strain in 3D, and the best views probably from 3D are from transesophageal echo to help, particularly valvular structure and interventions, et cetera, et cetera. So I mean, really, it has evolved so much over time. And this is 5 years ago, just 5 years ago, the technology of transillumination, if you will, where really, I mean, the images are beautiful as to almost having the structure of this mitral valve or other structure in front of you, almost having a, the valve itself in front of you. So if you tell me what does it look like in our evolution, you're living in the 20s, started with an A mode, M mode, 2D, Doppler, color Doppler, TEE, contrast harmonics, tissue Doppler, live 3D, speckle tracking with strain, live 3D TEE, handheld echo for point of care. Hopefully you don't abuse it and use it well, because it doesn't have all the blows and whistles. And point of care ultrasound, also in the critically ill patient, you'd better know what you're doing, right? And there's a new guideline coming out from the ACE regarding that, because you need good imaging and good interpretation in difficult clinical situations, right? So if you're using it and you need help, don't hesitate to ask somebody whose life has done this. And I usually leave you part of the historical perspective with this from Dr. Inge Adler, who is the father, in a way, of cardiac ultrasound, and how ultrasound was done in the 1960s. This is the new dress code for our sonographers. And a little drop. And probably the worst position to get an ultrasound. With your left hand in your pocket. And that's what you're able to see. All right? This is an A mode, okay, of a mitral valve. So, but it's amazing, actually. The amazing thing to me is the principle has not changed. The principle is just tiny wavelets that you're sending and getting back. And it's the technology, the transducer technology, and different questions. The first question was, can I see how far is it? How does it move? We still have those, but we ask a different question. What happened to the frequency of what we sent? And this is Doppler, right? So we have two principles, basically. One is depth and structure and actually imaging, and the other one is flow, which at this time, among all your other imaging technologies, this is the best to tell us about flow, velocity, and actual velocity from beat to beat. And hopefully you have a wonderful year. We will have the other imaging technology also talking about their basics. And I think that this should be a great basis for you to go and learn the technology so you can apply it to your patients. Thank you very much for your attention. Questions? We may have 2 minutes, 3 minutes for questions. Miguel, any reflections from you?
Oh, every time I see that video, I get teary-eyed. No, really, it's amazing when you think about it. Going from zero to what we got.
Any questions from fellows, trainees? All good? All right. See you. So, I mean, since you're here, we have imaging, multimodality imaging, October 5 and 6. I'm taking